and start. Hold on. We want to welcome you to ACMI stakeholders meeting, and today we're excited to learn about autism and autism in the adult population. And our speaker today is Dr. Christopher Smith, who's the Chief Science Officer at SARC, which is Southwest Autism Research and Resource Center. And I'm sure it's going to be a very interesting and exciting information.
Okay. Oh, you have a stand-up. Oh,
I only do interesting and exciting presentations. So. All right, if I could just, I'm not seeing this one screen where I'm sharing, where I'm in presentation mode, you know what I mean? That's what I could see it here. So let me see, it looks different, but let me see. Do you see that?
No, we don't see anything. Well, I don't see anything yet unless it's behind one of my multiple screens on multiple computers. Oh, now it's coming.
Do you see the big purple slide?
Yes.
Okay, so you know what's so funny? So when I'm doing this is all being recorded now, so you're capturing my ineptness for posterity. But when I was sharing it, I'm choosing that window, and it has the number. It says this is screen number 1. But it has my desktop. It doesn't have the slide on it for the presentation. But regardless, I'm good now that we have this. Okay. Do you want to give people another couple of minutes, or should we just go ahead and get started?
Well, since we recorded it, or we're recording it, let's go ahead and get started. Okay. And if they have any questions later, if they join later. The other thing is, do you want us to ask questions during, or do you prefer us to wait until you're done?
You know, honestly, I'm totally fine if people want to ask questions during the presentation, right? It makes it a little bit more informal, and it also makes it more informative, right? I think if people can kind of be more engaging or engaged during the presentation. So please feel free. Now, keep in mind, because I'm doing the presenting and I have a limited view of participants, I can't see everybody. So if somebody puts their hand up, Lori, just let me know.
Okay,
just interrupt me and say, hey, we have a question. So I'm happy to address that. Okay.
Okay.
All right, great. Yeah, you bet. Okay, so I'm Dr. Smith. I'm Christopher Smith. I'm the Chief Science Officer at the Southwest Autism Research and Resource Center. Thank you, Lori, for the introduction. I've been at SARC now for 16 years. Prior to SARC, I was at the Mount Sinai School of Medicine. In New York. I was an associate professor and in the Department of Psychiatry. And my expertise was, I was what was known as a phenotyper, right? For complex psychiatric disorders, in the sense that what a phenotyper does is you're able to measure different components of the presentation of a disorder, right? And that helps to kind of further, for the purposes the purpose of my position at the time was to further genetic studies of various psychiatric disorders. And I only worked in complex psychiatric disorders like schizophrenia, bipolar disorder, Alzheimer's disease, and then autism. And autism really became my main focus of interest in my career. And 16 years ago, I learned about a position here at SARC to be a phenotyper for a genetic study of autism. And we were able to kind of begin to work together. And I took the position, and we were able to begin this kind of large-scale genetic study of autism. And we since have shifted directions shortly after that study ended to make sure that we were not directing our own internal resources toward genetic studies, because the genetics of autism, as are many complex psychiatric disorders, are extremely complicated. And there's many other institutions around the country and around the world, really, that are we're spending billions of dollars collectively to better understand the genetics of these disorders. So we felt that our efforts are much better directed toward research that is likely to have a greater benefit on today's population. And that's where we decide to focus our efforts in research. We still contribute to genetic research, but for right now, we direct our efforts towards things that are focused on treatment. And I'll show you a little bit more about what it is that we do here. Okay, so for those of you who don't know, STARC has been around for 25 years, and unless you're in the autism community, you probably wouldn't know that. But we've been around for 25 years, going on our 26th year, and our mission is to advance research and provide a lifetime of support for individuals with autism and their families. That means we start as very early on with diagnostic services, then children's services, serving teen and adults and different intervention programs and community services and comprehensive treatment programs, going on up through life skills for promoting independence. And what I'm going to talk about more in adults now is we've done some research on the aging process in adults, and are in the process of developing interventions that are focused on helping adults with autism preserve their independent skills throughout the rest of their lives. So that's what I'm going to focus my lots of the presentation, but I'm going to take a little bit to get you there and give a little bit more information about autism as we go. So like I said, I'm the Chief Science Officer, and the research department at SARC has three main focus areas. One is on treatment efficacy, where we investigate behavioral interventions, educational or psychoeducational interventions, and pharmaceutical interventions, looking for better, more effective treatment programs for individuals with autism across the lifespan. Our original research really focuses on improving screening and diagnosis, and then developing new and exciting treatment approaches, which I'll talk a little bit more about toward the end of the presentation here. And then we provide diagnostic services across the community. And the reason that that's housed in research rather than in clinical programs is because all of the same assessments that we use to phenotype or measure different components of the disorder require this kind of developed expertise and skill set, which our department uses routinely in all of our research. And those same assessments are used to provide diagnostic evaluations. So it's the skill set of the staff that's in research to be able to provide that service to the community.
I have a question.
Yeah, please.
Sorry, it's early on, but
yeah,
I can't help myself. So
Go
you're a phenotyper of complex cases. So let's just say that how do you tease out if someone has schizophrenia, they're on the spectrum, they have a personality disorder, and they're traumatized? How do you figure out what's due to autism and how do you treat that? What's due to schizophrenia and how do you treat that? What's due to a personality disorder?
Yeah. That's a great question, Lori. I'm glad that you asked that, because it really kind of sets context for some of what I'm going to show you as we go forward. But the easy answer to that question is through the developmental history and the developmental trajectory. So many other disorders, complex psychiatric disorders like schizophrenia and bipolar disorder, there's a disruption that's limited to kind of a discrete episode of functioning that can be long-lasting and disrupt the pattern of that person's life going forward. And there's a cluster of symptoms that are associated with all of the different disorders that you looked at, that you mentioned before, that are distinct from autism. But now, if you are going to consider that autism is a part of this diagnostic picture, what you need to do, and it is the diagnostician's job, is to go back and look at the early developmental time period for that person and begin to look for evidence at that point that development was askew, right? That it was slightly different than what you would see in the typical developmental trajectory. And if you can do that, and the current symptom presentation is matching up with what the DSM-5 calls for autism, then you can make a diagnosis of autism. But you absolutely have to have evidence that the developmental trajectory was off track in the early developmental time period. Does that answer your question?
Thank you. That helps.
Yeah. Okay. So we are going to talk more about that, right? I'm going to go back though, and we're going to start with early on and what autism looks like, and kind of give you, I think, what I think is a very clear representation or description about what autism is. And it's a clear way to think about what autism is. And I think if you have that as a foundation, the rest of the presentation about what we think of when we talk about adults will make more sense to you. Okay, so this is a slide just to kind of make people aware that that autism is on the rise, and it has been on the rise since the 1950s. This table starts with 2004, when the CDC, the Centers for Disease Control, started monitoring the population rates associated with autism. And they come out with a report every few years. And the first report in 2004 was 1 in 66. And the most recent report that was issued in 2022 was 1 in 44, right? So that's a pretty significant percentage of the population. It's roughly about 2% of the population. And when you talk about other kinds of complex psychiatric disorders, they tend to hover right around 1%. Lori, do you have another question, or I just noticed your hand is up? Yeah.
Just a quick question.
Yeah.
Looking at this, is it that we have more autism, or is it that we're more aware of diagnosing it, or is it that societies have changed from being agricultural and people that didn't get well with others played in the field with horses, and now society requires better social skills?
Yeah. You know, it's all of the above, Lori, right? That's the best way to answer that question. It is a combination of factors that contribute to this rising rates of autism. Now, I'm not going to say that it's not the fact that we are no longer playing in the fields with each other, right? Because there actually is some evidence from Somali populations that they have less autism in that population in their own country back in Somalia, where kids are generally out playing with each other more often than when they come here and they don't have that same kind of network and community support. They have much higher rates of autism in those populations. And that's been replicated in different populations as well, as long as you have that comparison. But you can't ignore the fact that we've had revisions to the diagnostic criteria, very significant revisions in the last 30, 40 years that have contributed to this rise in rates, right? And anytime you change the diagnostic criteria, what they have done is they've increased the net, right? They've said, this is a broader net. We weren't fully understanding this before. The previous version was too restrictive. Kids were not being included under this net. And that's really intensely problematic, because if people are getting misdiagnosed, then the door for appropriate treatment for them is closed, right? And there are people that have gone a lifetime without getting the treatment that they need, a treatment that they know works, because they weren't diagnosed with autism 25 years ago, then they weren't able to be the beneficiaries of evidence-based treatment for autism in their early childhood, right? So we see that, and we know that that's a significant problem. But yeah, I mean, then you look into other things like technology and people being able to have this alternative method of communication that perhaps maybe they're more comfortable with because their social skills aren't as strong. And then, you know, there's theories that those people now meet each other and they start families, and that also then leads to kids with a different or additional social impairments because they have the stronger genetic hit, right? But we don't know that for certain. So that's why I say the best answer to your question, Lori, is that it's all of the above. right? And honestly, I always end, I get asked that question a lot. And I always end it with, ultimately, it doesn't really matter, because we know right now that there are roughly 2% of the population has an autism spectrum disorder, and they need support, right? And that's really where we need to focus our efforts, rather than understand why there was this rise. We need to focus our efforts on better supporting the individuals with the disorder. So, okay, so let's turn back the clock, right? Not for adults. Let me give you this clear example of what I believe autism is. And I think it's easy to understand, and I think you can see how things can present itself differently for people with autism if you understand this model. So we're going to start with an example of typical development, right? Typical development comes from typical learning and perception, right? That starts with the brain. When a child is born, they have a brain that is linked, that is receiving information from the environment. And what's happening is the information that they're receiving from the environment through social interactions is supporting a rapid development of, or supporting rapid development of social communication skills. And that is supported by different neural pathways that are being formulated in the brain during each one of these interactions that you see here, right? I mean, what's the common feature that you see throughout all of these pictures, right? They're making eye contact with each other, right? And then they're interacting, and you can see that it gets more sophisticated as skills grow, as kids get older. And those more sophisticated interactions leads to additional neural pathway development that's going to support more sophisticated social communication skills and development as kids get older, okay? That's what happens in typical development. There's nothing that's in the way. And now I want to just show this example of this, a video. This is a standard diagnostic observational assessment for autism. And this is a typically developing kid, okay? I think I shared the sound.
Here while I get a Coke. Oh, okay.
Okay. So I'm going to go ahead and play this video. You might hear the sound, you might not hear the sound, but really, I mean, just pay attention to what's happening. I'm going to talk our way through it as we go. Do you hear a sound? Lori, give me a nod if you do. Okay. Okay. So she's directing this little girl's attention to something across the room, right? Now watch. See how easily that happened, how smooth that was? Now she's something new's introduced. She's going to check back in with mom. She's going to make eye contact with mom, right? She's going to now check up with the examiner because now the bunny's making noise. She doesn't know what to do, right? So she's looking to see what is the appropriate thing for her to do. Right now she says a little something to the examiner, so it's like getting more sophisticated. Now I'm using language or bringing that in. And finally, we get a nice smile, right? So you could tell this little girl is engaged with the examiner. She doesn't know her. She's a total stranger, but yet mom and dad are in the room. She feels comfortable. She's paying attention to the cues. She has learned, she's developed those neural pathways that are going to begin to support that kind of interaction, okay? So let's go on. Sorry, let me click off that. Let's go on to look and see what autism looks like, right? And with a similar model, right? Autism, it starts again with the brain, right? Because all children have brains. And then we have disrupted learning and perception. There's something that is getting in the way of the learning process for individuals that have autism. So they're all kids with autism are experiencing the same interactions, right? But the information that is getting into the brain and developing, and skills that are developing, is happening so much more slowly than what we see in typical development, right? And because there's something that's interrupting this learning and acquisition process and skill development process, what we see is that that kids with autism are experiencing a developmental delay, right? Now, does that make sense to everybody? Like, just give me some nods, right?
No.
So if you were to think about like that and just a little differently, right? If I was to take a textbook of, let's just say, algebra, okay? And I'm just going to name people that I can see on the screen. Dick, if I gave you a textbook on algebra and I asked you to read it, and I said, study this, go to a quiet place every single day and read that information that's in there. And at the end of each week, I'm going to ask you some tests, some algebra tests or questions, and I want you to answer them. And then, Jennifer, if I gave you the same book, right? And I said, I want you to read this book, but I want you to have the TV on in the background. I want you to take phone calls as they come in. I want you to have this kind of live your life while you are trying to learn this material. If at the end of 3 months, I gave Dick and Jennifer the same algebra test, who do you think would do better?
Jennifer.
No, Dick. No, you would do better, right? Because you had an efficient learning process, right? Jennifer, you would have experienced disrupted learning, right? Because there were more things that were kind of getting in the way from you acquiring that information. Now, with autism, it's the same thing with autism, right? Your development of algebra, Jennifer, would be here, whereas Dick, because he didn't have disrupted learning, his development in algebra would be up here. And autism is the same thing, right? And the disruption that's caused to the learning process that causes a slower development of skills just means that this kid with autism, their skills are moving forward more slowly, whereas typically developing kids that don't have that disruption, their skills are developing rapidly, right? Very, very significantly faster than the kids that have autism. Now, there's a lot of different presentations of autism. Some are more severe early on, like they don't develop even the basic skills, and some are less severe. Some they develop basic skills, but maybe they're not as good at relating to peers, or maybe they develop these other habits that makes it hard for them to develop more peer networks, or makes it difficult for them to understand how to process information in their environment at any age, right? So for kids like that, I mean, they're probably pretty close to where peers are throughout most of their lives. And then as things get more complicated for them, peers continue to excel, but people drop down or drop behind. And that can happen at any age. And we're going to see that in the diagnostic criteria. Anybody else have any questions about that? Any comments?
I
Does that
have
make
a
sense
quick
to people?
question.
Yeah.
So do you actually see during the development like regression, like even losing skills that they priorly had mastered?
Yeah.
Or is it just a slowing that the peers are ahead of them?
You can actually experience regression, right? And like let's think about what that looks like, right? Did you ever take a language when you were in high school? Did you take Spanish? Did you do well in Spanish at that point, right? Or now I don't know how far you're out from high school now. Can you speak any Spanish?
Pretty far. I actually learned French in high school and college, but I can barely speak it now. So
Okay.
Yeah.
You've experienced the regression, right?
Yeah.
And mainly because like you're not using those skills, right? The using or losing it. You're not motivated and you don't have a necessity to use the Spanish and the French language that you learned in high school and college. So you're regressing in those skills. Similar things can happen with people with autism, right? But it's generally related to social communication or adaptive skills. For whatever reason that's linked to autism, that individual is not motivated to interact with others. So they may regress in their language skills. They're not motivated, or they don't have it's not rewarding to them to have this kind of conversation with people or ask for things instead. So their skills start to drop back, right? So if they're not motivated to keep using those skills are most likely going to regress and fall off. Okay.
I
Yeah.
have
grandson who's about 23, who's autistic. And when you talked about the disruption, I found it really interesting. A few years ago, when he speaks, he has echolalia.
Mhm.
He doesn't repeat syllables, he repeats words and phrases.
Yeah.
I think that's what it's called.
For
And
sure.
I just asked him, he's very open about his autism. And I said, Jacob, what's going on when you're, trying to talk to us and, you repeat. He said, well, Grandma, he said, it's like like you would be trying to skip a stone on a lake and you throw out one stone. And he said, but instead of one stone, when I pitch it, 30 other stones come. So
Yeah.
he's saying when he's trying to get a word, he has more than one word coming into his brain.
Yeah.
And I thought that was an interesting description of being disrupted.
Yeah, for sure.
And
And
he tries to speak.
it's great that he can articulate that.
Yes.
Generally, like what we kind of think is happening with echolalia and people that repeat phrases, if we go, there's fluency, right? Language fluency, being able to pull all of these different words from their head and use them to communicate is difficult, right? That is a sophisticated skill. And if they don't have that skill of fluency, what they tend to do is say what's familiar to them, right? So instead of saying something more functionally, they may just repeat themselves or just repeat what you said because they know they want to respond, they know to respond, but I'm going to say this word because I have that easily accessible in my brain, right? So yeah, so that makes a lot of sense that all of these other words are coming, right? But the one that he can get out is the one that's already out, and it's going to repeat and it's going to repeat and it's going to repeat because he has limited fluency, So, okay, so let's just go to watch this video, right? Because now I showed you a video of what typical development looks like. This is a video of a girl of a similar age doing the same kinds of things in the same kind of assessment. And while I showed all of those examples of eye contact and social connectedness before, let's watch what happens here. So here, she's sitting down, she's playing with a toy, she's not looking at the examiner and not looking at her mom. I want you to also kind of watch mom's face here, okay? While you're doing this. Now the examiner approaches, but she gets up and she walks away. Not looking at her, not trying to engage, nothing. As a matter of fact, almost avoiding it.
You know where that goes?
Now she's talking to her, doesn't look up once. And she's banging toys together, but never once does she attempt to engage with the examiner or the mom. And you see mom's, she was smiling through that, right? And I think partially it's because this little girl is not doing anything that is terribly problematic, right? She's not hurting herself. She's not banging her head against the wall. She's not making odd sounds. She's not engaging in other much more obvious behaviors. She just looks like she's playing very independently. And mom thinks, okay, that's fine, right? But now what's happening though, right? Remember, like that early picture of development where people are making eye contact, kids are making eye contact with other people around. Consider the eyes as kind of the input device to the brain, right? Like, so if you're looking up at other people and you're seeing them make a facial expression or you're seeing them talk to you, that's going into the brain and helping to formulate neural pathways that are going to support social communication. This little girl was not looking at anybody, right? So in just that few minutes of video, and I think it's probably about a minute and a half, there were 5 or 6 missed learning opportunities that are going to contribute to her development, okay? So just like with the algebra question before, if you look at the other little girl that makes 5 examples of eye contact, responds with language, responds to language, laughs, enjoys the interaction, and then you look at this little girl who's having a more rewarding learning experience that's going to contribute to their development? The first girl, right? The first girl is the one that she's getting more information. She's going to develop more quickly, whereas this girl is getting less information. She's going to develop more slowly. Okay, so that makes sense. So that's why autism is classified as a developmental disorder, right? It's a pervasive developmental delay. And the pervasive part is that it affects so much of their presentation, of their development, that it's widespread and it causes their development to move more slowly than what we would expect in typically developing individuals. And I'm going to say that even though like this little girl, like I said, she's not really doing anything that's terribly problematic or bothersome, but she is having this disrupted learning process. And if she wasn't detected early, it could be a very long time, years of that disrupted learning process before a problem emerged and before she needed to get a diagnosis, okay? So let's just review quickly what are current early indicators and versus later indicators, right? Certainly no language, right, is a problem, right? Kids that are not hitting their language milestones, that's a problem. If a child doesn't respond when their parent calls their name, the parent's going to see a problem with that. If they are losing language skills, it's like, wow, last week he was talking so much more, and now I don't hear anything this week, that's going to be a problem. If the kids don't look at parents, that's going to cause a problem. Lining up toys or playing with toys differently, no interactions with people, difficulty engaging, like if somebody's trying to play with them and they don't engage, those are all things that are going to cause problems for caregivers, and they're going to seek an evaluation. But if they do that stuff, right, and let's just say they do some of it, but they don't do it enough, that's going to foster their development, or they do it less than what is expected, right, then they're going to get less information that's going to contribute to their development, and they're very likely going to fall behind at some point. And there's all some sorts of questions about that, right? I mean, if I asked you, I'm sure there's lots of parents in this group, how many times should a toddler look at their parent during the day? How many times? Somebody just jump in. What do you expect?
500.
500, right? I mean, you think that. So would a parent know the difference if the kid only looked at them 300 times or 200 times? I mean, they're still looking at them hundreds of times, but they're just not doing it the same amount that you would expect to foster typical development, right? So that is potentially leading to something that's going to be a delay for them later on in life. Now, later indicators might look like, so kids that get past all of those early warning signs, right, and that they do these things enough to make their parents satisfied. When you get to the older kids, what does it look like? How do you know that you're heading toward a diagnosis of autism at that time? Well, it's an impaired ability to make friends or a sustained conversation or relationships with people, and an absence or an impairment of an imaginative play. Like, so just imagine if there's 4 or 5 5-year-olds all playing with house, and a little girl is there and she's like, I don't know what to do here, so I'm going to go off and I'm going to play with these blocks, or I'm going to bounce this ball repetitively across the hall. She's missing out now on that interaction with those kids that are playing like that. So she doesn't have the interest or the resources to get involved in those, and she's missing out on learning opportunities. Anybody that has any kind of repetitive behaviors or restricted pattern of interests, kids that are only interested in, say, like washing machines or toilet bowls or street signs. It's really hard to find other kids that are interested in toilet bowls. Like, you can't kind of build a friendship around your interest in toilet bowls. Preoccupation with certain objects, or an odd adherence to specific routines, like you got to take the same route to Target every time, or if not, there's a problem and you're rocking my world and I'm going to tantrum as a result of that. All of those things are kind of later indicators of kids that get by those early, very early, more obvious signs the delay can begin to emerge and look like these kinds of things later on in life. Lori, I see a hand up. Do you have another question?
I was just wondering if the later indicators are even later into adulthood or just
Yes.
later toddlers, later teens.
Absolutely. I mean, these types of things can emerge in later children, like say school-age children. We usually find like there's another kind of sweet spot around 3rd and 4th grade at that point, and really like peer networking becomes much more sophisticated around 3rd and 4th grade. So kids that are not able to do that are tending to fall behind or being ostracized or even bullied, right? And they're not getting kind of identified or picked up at that point because it takes a little bit more for something else major to happen. Melissa, I see a hand up.
Yeah, thank you.
Yeah.
And looking at the images that you showed before, do you understand sort of the disruptions that might be physical, the environmental ones? For instance, the walls were white in at least the one room, but the door was a color and there was a blackboard. So is there some threshold to like maybe those negative physical disruptions, obviously like noise too, but then are there positive positive type of interventions in a physical environment that might help?
So that's super interesting. So generally, right, because we know that typical development is extremely resilient, right? Like kids that are typically developing will display those skills in multiple environments, right? Across multiple environments. It's generally not limited to one that has something that's not preferred, right? So we don't spend a whole lot of time studying like the environmental aspects. Like we wouldn't say take that second little girl and say, well, let's move her to this room and try that, because if she demonstrated those impairments in the one room, we have to act on those impairments, right? It's not about like, well, let's alter the environment to see if she can display better skills. We have to look at the impairment and the skills that were demonstrated at that point and act on those, right? Because the world doesn't tailor their environment to keep people's functioning, right? People need to bring their functional skills to multiple environments to function. Does that answer your question?
Yes, thank you. I guess I was also and I appreciate that. That makes all kinds of sense, but also thinking, for instance, there is research about, again, kids that don't have autism, but for example, improved learning or testing scores, in different, with different things, whether it's access to daylight or views of nature, et cetera, et cetera. So I don't know if there's any benefit like that might apply at certain times.
Yeah. I mean, it's not in our scope of practice, right? And it's not in the research that we would do, because again, like, that focuses more on kind of tailoring the environment to the individual's needs, which, I mean, some of that is acceptable. But when you're looking at development that is behind, we need to work to get development to move forward again. And that's generally through intervention. So that's our approach, right? There are different approaches out there, but I can only speak to what we believe and what our approach is. So Rachel, I see other hands up, so I want to keep moving on because I want to get to the rest.
Yeah, no, most of my experiences with the psychosis and schizophrenia population, and that is also neurodevelopmental, neurodegenerative, if not treated. And a lot of those kids have early diagnoses of ADHD, ADD, learning disabilities, social anxiety. A lot of these later indicators, maybe not so much the early ones, are overlap. Obviously they go into two different paths, but how can is there any indication of, hey, this one is heading toward autism and this one is heading toward psychosis? Is there any key things?
So really, I mean, like the early developmental time period is a key element, right? Now, I mean, sometimes psychosis and schizophrenia and bipolar disorder, I mean, they can all have like a very long prodromal period of social isolation. There's lots of gray areas here, right? But certainly that social isolation that emerges in early adolescence, if somebody's heading towards psychosis, if there's those would be more of the negative symptoms that are associated with schizophrenia, right? Like the social isolation, not talking much to other individuals. If there's no other kind of positive symptoms that are associated with autism, like restricted interests or repetitive behaviors, like you need those components to think more related to autism. If it's just really social isolation, then it's going to be challenging. But the only other then differentiator then is to back up again and look at the very early developmental time period. And honestly, I mean, that takes a lot of skill, right? And a lot of experience to like know all of the different manifestations that are indicative of a developmental delay, but in the very early childhood years. Otherwise, what you're going to get is you're going to say to parents, well, were they talking? Oh, yeah, no, they started talking, no problem at age 2. You know, well, what kinds of things did they talk about? Well, everything that normal kids do, you know, they're not going to be able to report to you the details that you need. But if you have some other kind of indicator like, well, yeah, they hand flapped quite a bit at that time. Or I remember that they were so focused on Dora the Explorer, right? Between 2 and 3. And did that cause any problems? Oh my gosh, you would tantrum. We had 3 or 4 Dora the Explorers just to make sure that that. So now you're getting some evidence that there is something that's related to autism in the early developmental time period that could suggest that that disruption was learning and learning was present there. But I want to caution you too. Like if somebody starts to develop hallucinations and delusions and active psychosis, that's the aspect that needs to be treated, right? Because treatment for autism is not going to address, active hallucinations and psychosis, okay? So that becomes the more predominant clinical picture at the time. Lois, I'm sorry.
You're on mute, Lois.
Lois, we'll come back to you. Are we
It's okay,
Go ahead.
go
I see.
on.
on.
Yeah.
We hear you now. Go ahead.
Oh, okay, I don't want to be inappropriate time. I think I brought this up with the group before about Dr. Anderson that works with Barrows and young autistic kids at Children's Hospital.
Mm-hmm.
And he had discovered or found out that by using, I think it's a cancer drug, that the life of the kids with autism had brightened a bit. They were more interactive, something. I could never find out anything further. I talked at length with his, I think, receptionist.
Yeah.
And that ended there. Is it possible with all of this in early schooling to find out if they do lack folate, the ability to metabolize it and start any kind of intervention? Because this thing that Dr. Anderson found was something that made folate get across the brain barrier.
Yeah, right.
We have MTHFR in our family.
I am,
and we do not process folate well.
I'm aware of that research, right? And I know that there's research that's happening right now, large scale research. So I'm not going to say that it's not possible. What I am going to say is that it needs to be studied, right? Because there are many of these kind of red herrings that are out there. And I'm not saying that that is it, right? But that where it looks like it's good and anecdotally it has great promise, but they don't stand up to the gold standard of science, which is double-blind, placebo-controlled trials. But there's some good science in this area right now. So stay tuned for that is what the best thing I can tell you. So I'm going to jump over to Nadine.
Yes, I had heard somewhere that this eye contact, like you were talking about as infants, was very critical. But a lot of parents are now using a pillow or something like that to prop up the bottle. So the babies are not having enough interaction and eye contact with their parents or caregivers.
So eye contact is critical, right? It is a gateway, right, for providing information to the brain. I will say, I'm going to draw back to my last comment that typical development is extremely resilient, right? So you're like by feeding a bottle, remember if they are looking at making eye contact with the caregiver 500 times throughout the day, they might be missing 20 opportunities during that bottle, right? And it really shouldn't affect development, right? So yeah, I mean, that's not going to be enough to deprive them to set their developmental trajectory off course. But I will say too, that even unless a kid is falling asleep, and very young kids too might be doing this. Parents of young kids know it is hard to get a few minutes to yourself, right?
Yes.
Without that kid seeking your attention, right? So kids should be seeking parents' attention. They should be craving that information. They should be motivated to seek that attention. And if kids are not, if they're content by just sitting by themselves, and like one of the most distressing things I hear as a clinician is, oh, he was such a good baby. Whenever I hear that he's a good baby, I always follow up, but what does that mean? Like you shouldn't be able to put a 2-year-old in a room in front of a TV for 2 hours. Like that's not, no, my kids never did that. You know what I mean? Gosh, if I could get 2 hours without them, even if I left the room, they would still be
pretty
seeking my
placid.
attention, right?
You were
That's
placid.
really critical. iPhone, I don't see your name. Sorry. I don't. It's somebody with a tan hand, looks like a sleeveless shirt.
Holly, that's you. You're on mute.
Only you're on mute.
I know it's challenging. Got to look for that unmute button. We can come back to you. You can always ask your question. Lois, did you have another question? Your hand is still up, I see. You're also on mute, Lois. We'll come back. So that's why we are firm believers of early identification and early intervention, and that's generally because we want to get kids into treatment while the brain is at its highest neuroplasticity, right? And it's most flexible for learning and developing skills. And one of the things that we do is promote screening to the general public. And we have an early access to screening program. So if there are people in your circles that have concerns about their young children, you don't have to wait for your your well baby checkups. You don't have to rely just on your pediatrician. You can call SARC for the early access to screening program and get screened by our staff, and we'll guide you on what the next steps are. So
what do you do for the adults that have it, especially adults with SMI? I mean, they're down the road. They're beyond 18. They're beyond 21, a lot of them.
Right. So what we do, if that's the case, we don't bother with screening, right? If you're an adult, if you're over the age of 4, 5, 6, somewhere in that area, just go get an evaluation. That's the best thing to do, right? Because you're going to get in front of an autism professional who knows to ask all of the questions that are going to satisfy DSM criteria, right? So that is your best course of action. So if you have somebody that is an older child, a teen, or an adult that needs an evaluation, they should seek to get a diagnostic evaluation for autism. That's the only thing that's going to give them the answers that they need. Does that make sense? Okay, so just to understand a little bit more about what autism is according to the DSM, it used to be 3 distinct constructs, right? We used to have social, communication, and behavior, and you needed impairments in all 3 of these areas to meet criteria. But what we've since learned is that it's not really 3 constructs, it's really 2, because you can't have social impairments and not have communication impairments, and vice versa, right? So really it's social communication impairments, and you have to have this cluster of restricted and repetitive behavior. And that is true of any age, okay? That's what where the symptom clusters lie. It's all things related to Do you communicate with language? Do you communicate non-verbally? Are you able to develop relationships? There is more details associated with each of those symptom clusters, but you must have an impairment in that area. And then you also have to have some impairment in behavior too, to meet criteria for autism. And, for those of you that are trying to make differential diagnosis and you're saying, how do we know if this is autism versus schizophrenia or bipolar disorder? Generally with those other symptoms or those other disorders, what you're looking for is the discrete onset and period of effectiveness with a clear onset and offset of those episodes. Like that doesn't exist in autism. Autism is a lifelong condition, right? These things should have been always present and should have been maintained in some form throughout the individual's life. So there is no discrete episodic functioning or impairment in functioning with autism. If there is something else, if you're seeing that in a client, then you should really be looking at another disorder as well. And it's also important to know that, there's variable presentation in autism. If you just look at these ranges across these three major areas, right, that are associated with autism and other disorders, there's a range in cognition from significant cognitive impairment all the way up through gifted. Communication, there's no functional communication to near typical communication. And then socialization, no desire and limited skills. And then on the other end of that spectrum is strong desire and also limited skills because of that learning impairment. All of this exists within the autism population. So in this business, we have a phrase that says, if you know one person with autism, you know one person with autism. You don't know anything more about autism other than what that one person is presenting to you. And here, the point of this slide is to show you that it can take various forms at different ages, right? So obviously the younger kids are the most easily detected when they have those more significant impairments. But other things, when you get older, if they don't have those significant learning language impairments, then you start to see more things like social isolation and depression. You start to see these other things start to creep in that kind of garner the attention of clinicians and look to require more immediate treatment, right? Because somebody who's depressed and potentially suicidal, that's the part that's going to get treated rather than the looking back throughout their history to see if there's an enduring social impairment that needs addressing too, right?
Hopefully
and that's often how.
Yeah. Hopefully the
That's all-
psychiatrist will look at that too and not just think it's depression. We have a
Right.
question. Holly's back, so let's see if.
Yeah, of course.
Hi, thank you. Could I ask you to comment on adults with autism and treatment opportunities there? ACME as a group focuses on the chronically seriously mentally ill, which in Arizona means by definition you have to be over 18. My specific interest is in what we need to be looking at. For instance, our state hospital does not have autism treatment programs. They have testified to that, explained that.
Yeah.
We understand they may be asking for funding, but I am particularly troubled as an attorney when I have patients who have autism as their primary diagnosis, followed by antisocial personality disorder, followed by schizoaffective disorder, followed by bipolar disorder,
right.
and they're on 11 medicines. So what's the current state of the art in treating adults who are in either state hospitals or are court ordered into an inpatient facility with a primary diagnosis of autism and maybe another couple of serious mental illness diagnoses that qualify them for serious mental illness?
That's a very in-depth question, Holly, right? And I appreciate the need for you to look for this information, but I'm going to tell you that there is no current state-of-the-art treatment for that, right? There isn't. It just doesn't exist. And the reason is the current evidence-based treatment approaches for people with autism is about building skills that is related or that's going to support that individual's optimal level of independence. Okay, so if you let me go back to this slide here, right? So what I'm illustrating here is if autism is undetected through these early years because of skills, because of neglect, because of, just undiagnosed issues or no problems associated with any of the behavioral manifestations, that person's skill set, right, or their ability to connect with peers is going to be impaired. And what happens to individuals when they can't function as well as in their environment as their peers? They generally head toward depression, right? Or they may have other types of diagnoses or other types of glimmers of autism that are emerging and causing problems to that individual. And those are the symptom clusters that are going to garner attention by general psychiatrists. And general psychiatrists are not generally autism experts, right? So they know to treat this symptom cluster that's going to come up. So they're going to treat that person's depression because they can. And quite honestly, it can be severe enough, even if that person has autism, it can be severe enough that that should be the primary focus of treatment at this time, right? So it's kind of like this double-edged sword. Like if somebody does have this severe anxiety that is crippling to them, the recommended treatment program for autism is intense therapy with applied behavior analysis. And that takes a long time. And that's not something that can just be implemented in a hospital setting. And it can't be implemented, in just 30 days to help alleviate that person's anxiety. Remember, it is a lifelong pattern of disrupted learning. And there's no gold standard treatment approach that's going to undo that in a timely manner that's going to help address that current person's current serious psychiatric problem. So that's why you see this, like you see these people with these very complicated psychiatric histories, and they come to us for diagnostic evaluations, sometimes in their 30s, and they have been diagnosed and treated for everything under the sun: OCD, anxiety, depression, bipolar disorder, ADHD, everything. We see it time and time and time again. And I'm not saying that any of those disorders are incorrect. What I am saying is if they were identified earlier and treatment was implemented earlier, we may have avoided those other issues. Right? But there's no way to go, have no crystal ball.
Well, in these cases, in the cases that I'm talking about, these are all people who have been diagnosed since childhood with autism. And in one case, treated by a really great Dr. Levine at PCH for years. Then they get into our SMI system, and which doesn't deal with autism in adults. And they end up in justice involvement, committing very bad crimes. And they end up at the forensic hospital. And in some instances at ASH, they will leave autism as the first diagnosis. In other instances, they'll say, no, Dr. Levine's wrong. This SARC was wrong. They never had autism. And they just take it off the list because they can't treat it. So I guess what I'm asking is, if somebody is in a hospital, they have a lifetime diagnosis of autism, and then at age 18, they layer on some additional diagnoses that fall under the SMI designation. Can you ignore the autism and treat the other SMI diagnoses, or do you have to do it together?
Well, I don't like the term ignore the autism. You can't make it go away. I mean, if you have this longstanding history of a disrupted developmental trajectory, well, then you can't ignore that. So it doesn't just disappear because they got something else. And I think the most important thing that I could say to this, right, is there's nothing that protects an individual with autism from developing another disorder. I mean, they're
Right.
just like everybody
Right.
else in the community. They are prone to depression, they are prone to anxiety, they are prone to, I mean, they could potentially engage in illegal behavior, like whether or not that's social
Sure.
naivete or whether or not it's because they got involved in something that they shouldn't have been involved in, right?
Mhm.
So, I mean, all of that can exist within the autism community. So I don't think that there is a simple answer to your question, but I don't think I'm not a fan of just ignoring the lifelong course and the previous diagnosis. But I will say, if there is something that is leading to hospitalization, it is important that that be treated as best that they can. And for some, that's going to be treating, recognizing that this individual has autism, and maybe it's a good behavioral program to get them out of that pattern that they're in. And for others, it may be too extreme and they could be a danger to themselves or other people, and they need to be treated with medication. Yeah, right now there is no gold standard treatment for autism that's medication related. There are 2 drugs on the market today that are FDA approved, and that they are risperidone and Abilify, and
Right.
they are approved only for treatment of irritability in autism. So irritability and aggression in autism. And now not every person with autism has irritability and aggression, but sometimes that irritability and aggression is such a barrier to any other kind of treatment or behavior, and it's making their lives miserable or their family's lives miserable, that it needs to be treated with medication. Like that's just the best option for them at this time.
Thank you.
Now, I would recommend that they do that and they engage in a lengthy behavioral program to address whatever it is that their irritability is related to, and just develop better strategies for managing their irritability. Right?
Thank you.
And
That's very helpful.
Yeah,
And
sometimes people without autism also need that kind of behavioral program to help them deal with their irritability, right? I mean, that exists too. So yeah.
And you're talking about individual therapy is like 30 minutes a month sufficient for that?
No, never. I mean, you can't learn a new skill in 30 minutes a month, right? I mean, recommended, it varies, but generally for little kids, let's say, it's 25 to 40 hours of intensive intervention to get that development on course per week, right? So 30 minutes of something isn't going to do anything, right?
Even if you're an adult.
Even
for
if you're an
adults.
adult.
Yeah,
even if you're an adult.
Thank you.
Most adults in our programs, like we won't enroll an adult in any of our treatment programs if they can't commit more than 7 hours. 7 hours or up per week, right? Because that's what it's going to take to help change their behavior. So
thank you.
Okay.
How many more slides do we have? I know I asked you for 30 to 45 minutes. So are we?
Yeah. I mean, I can fast forward to some of these, but these are good discussions. I can skip through this. So this is the current diagnostic criteria. I think some might be interested in this. And I think the most important part on this slide is what we want to do is that symptoms can be present. They must be present in the early developmental time period, but symptoms may not have been fully manifest until the social demands of the environment exceed the limited capacities of the individual, right? So that's demonstrating that learning impairment. That's why you can have a person who's diagnosed at 12 or 15 or 20 or 25, because at some point they've reached this area that is where they are not functioning well enough as well like their peers, right? So that's an important diagnostic criteria for people to understand. Okay.
And Dr. Smith, can we get the slides later so we can also?
Yeah, of course.
Okay, thank you.
Of course. When do you? I have this on my calendar till 5:30. Is that accurate still, or are we worried about?
Let's see, we have a few members that want to talk about their family situations, but we could probably go for another 10 minutes.
Okay, that's fine. So here, let me click through this, right? So we won't go into this. Let me jump right to what we're doing. about, kind of addressing these types of treatment programs for teens and adults. There aren't any very good, effective programs to address all of the issues that teens and adults experience with autism, and we recognize this. And what we're trying to do is identify what we need to focus on, and helping people develop better cognitive compensation strategies, develop and maintain social relationships. And we're also engaging in mindfulness-based emotion regulation strategies to help people deal with all of the things that they're experiencing that are placing functional limitations on their lives, right? So we have a study that's funded actually by the Department of Defense, federal funding, which, if people don't know, I mean, they do fund research on psychiatric disorders. And this is a collaboration between us and ASU and Mayo Clinic. And it's based on past research that looked at the brain functioning in adults with autism, and learned that adults with autism are at risk for more rapid decline in some brain functions than what we would see in typically developing individuals. So it makes a case for the need to continue intervention, right? So they're maintaining the skills that they've developed and not losing the skills that they developed. And the part of the reason for that is to improve their quality of life and help them to avoid engaging in these more serious psychiatric conditions. Lori, hand up.
I was just going to say that ties in with a lot of the Alzheimer's research and lots of others, because socialization is one of the protective factors.
Exactly.
And if you don't have the socialization skills, you probably don't have the socialization and therefore not protected, right?
That's exactly right. And actually, like, we've learned quite a bit from the Alzheimer's research. And there is a treatment program called Habit that's geared toward people that are experiencing early dementia, and helping them to maintain their skills. That is incorporated into this program that we're doing for adults, right? So it's social skills maintenance. The cognitive maintenance is really more related to Habit. And then the mindfulness component is just to help people begin to process the issues that they're dealing with in their lives, and hopefully keep people out of hospitals, right? So we're just about kind of wrapping up this study right now. But what we're finding is that the participants are rating all different components of these scales very high, and they are enjoying it, and they're seeing benefit from it. Now, we haven't finished the study yet, so we can't show that people have gained skills since their baseline appointment just yet. We have to finish the project, but we know that they're doing very well with the program components. So that's a very positive thing. And then this is just a comment from somebody that's in the group, 42-year-old female response, right? She shared this on social media. She started a program that took a lot of personal strength to be a part of. It helped her improve or adjust pieces of her life that made a more positive, functional, and healthy impact. Learning about mindfulness to help navigate emotions and feelings. Like that gets back to that learning impairment as adults. Like, we should have good emotional compensation strategies. And if you have a learning impairment, maybe that's too sophisticated that you haven't learned that just yet. So if we can teach that, then we can help adults master the skills to manage their own emotional functioning. And then she makes a comment here about the breakdown of how to connect, interact, escape, or ensure that you understand how to engage and be a part of a conversation in a healthy, productive manner. So that to be really beneficial. And again, that's leading to a more enriched and rewarding life that helps to hopefully prevent against other kinds of mental illness. So we think that this program has great promise, and it's really important that we are able to engage with adults with autism in this manner to help give them some beneficial tools to protect their emotional functioning. And I'll stop there. I mean, I feel like this was a very good discussion. I appreciate people's engagement and questions that they ask. And I'm happy to take a few more questions if you have time. That's I'll leave that up to you folks.
Does anyone have any follow-up questions? I mean, I'd love to get the slides and I'll send it out to the group.
Yeah.
I think it's really interesting because of how often we see people on the spectrum that I think it contributes to the ACEs that then can trigger more psychiatric illness. You know,
Yeah, for sure.
It's very difficult.
So what I'll do, Lori, is I'll pull the videos out of the slide, right? This presentation that was preventing it. So you just won't get the videos, but I'll send you the other slides and you could share that with the group and people can reach out if there's questions.
Thank you very much. And if you'd like to stay on, please do, but I know a few members, I'll stop recording this part of the meeting